All right, and welcome to mini number 6, finger and thumb and hand positioning. So here's what you're going to need to know. Here's a little one. It's a 10 by 12. Here's the image size receptors that we normally use, the 14 by 17s. So where are you going to place a finger for an x-ray? In the center of the board. Make sure your patient has all the rings removed and that there is no overlying jewelry or anything in the way. So here's what we need to know. All right. Every single finger is a different CPT code. You cannot x-ray all the fingers together and have it count. A radiologist is going to read one finger at a time. So if a doctor wants all 5 fingers done, he's going to need to order all 5 fingers. All 5 fingers will have to have a separate CPT code and a diagnosis code. All right. So some things you need to be aware of is, what if your patient has a contracted hand? You'll see older folks, it's called contractures when the muscles start to go together like this. And sometimes what we can do, I'll show you a trick. Sometimes what we can do is put a washcloth in the hand. Sometimes what we do is, if I can get them to hold a cup, that will spread out my fingers enough to see. The OID is going to be off, yes, but it's still better than taking a picture like this. Sometimes you have to get a little crafty and creative. I'm going to use, say for instance, we can use a pin to push a finger out of the way like that. We can also use tape or gauze. I've been known to tape a finger and help it come back out of the way if patient is contracted. Now, if they have injury, please don't do that. Try and just do the best possible for the patient. So we have our finger in the center of the board, and say we're x-raying number 1 here. The central ray is going to enter perpendicular to the plate, which means straight up and down. The finger has to be right, and it's going to enter the PIP joint, which is the proximal interphalangeal joint. And holding up my finger, that is this joint right here, the second knuckle. All right, so the CR is entering here. Now, you need to collimate all 4 sides, and I collimate to the middle, to the hand. All right, this bone is not included in a finger x-ray, but we need to have that joint of this knuckle right here included on the finger x-ray. So a PA is first. And then we can do an oblique, which an oblique for a finger would be like this. But it's a little bit more difficult to do when you have from this side, right? You have to move your arm in all kinds of weird ways. So your first finger turns naturally like that, but not like this, because you would have a great deal of distance in between these two. Turn your finger inwards like this, get the thumb out of the way, and your patient can do that. Now, for the rest of the fingers, it's easier to roll just slightly that way, right? It's not as easy to do this. So sometimes you just have to practice it on yourself and show the patient what you want them to do. You turn your hand and say, this is what I want you to do. Turn your hand just a little bit to the outside, and you can help separate out their fingers to where you can shoot a lateral or shoot an oblique as best as you can. Now, this also comes into play with the lateral projections. So the routine projections for a finger is a PA, oblique, and a lateral. Let's show you the lateral for a pinky. Okay, we're just going to ball up the fist and put it right there. But then getting a lateral, any other finger, is just more difficult. All right. We want to try and get that finger out there, and sometimes it may require getting a popsicle stick and holding it out. Now, we don't want to make the finger not in line with the image receptor. However, we could also maybe get a wedge, get a sponge so that they can hold their finger up there steady. Getting into the middle finger is a little bit more difficult, and I find sometimes it's easier to hold it out like this rather than hold it out like this. Just depends on the person. I'll say, yeah, you're not flipping me off, but I want you to do it like this. But you still also have to make sure that your other fingers are not superimposed over the one finger that you want to see. All right, so then the central ray would again enter the the pip, the proximal interphalangeal joint right here in the second knuckle. So coming back to doing a lateral of this finger, would I do a lateral this way and have, approximately 3 to 4 inches of space on SID? No, I'm not going to do that. I'm going to have the patient turn their hand over and do a lateral, because that places the finger in line with the image receptor, makes it more parallel, and gets it closer to the image receptor so that there isn't a big distance distortion. All right. So that's the projections for a finger. On an evaluation of the finger, you're supposed to be able to see the trabecular bony markings. You're supposed to be able to see the finger without superimposed other fingers over it. The CR should enter correctly to the pip joint. And yeah, that's it for the finger. So for a thumb. Now, a thumb is an interesting little handy-dandy little guy here. When you naturally set it down, it's in an oblique position. Okay, you can shoot that naturally as an oblique. However, for a thumb, you must collimate all the way down to approximately this far. It has to include the trapezium of the wrist, because that is where the bone articulates with the thumb, right in here. And that's the only one that we have to go that far down on. All right, so that is a natural position for a wrist. The CR enters the metacarpal phalangeal joint, which is this guy right here, perpendicular, and this is an oblique. Great, right? So then how do you get an AP thumb? And because we're not going to do this would be a PA. This is a PA thumb. So the routine projection for a thumb is an AP, oblique, and a lateral. So if I flipped this finger to have this side down, which involves rotating my hand all the way around, you can see that that puts that down onto the image receptor. All right, then you have to line up the hand to be just right. The central ray will then enter the same MCP joint. And sometimes on some patients, the hand has to be held back, or you can put a little bit of a sandbag there to help pull those bones apart. And you shoot right in there, perpendicular. And that is your AP thumb. Now, this needs to also include all the way up into the wrist joint to see that bony connection. Oh, I just wrote over myself. To see the bony connection between the thumb and the trapezium. All right. So then what's left on a thumb is a lateral view. Rotate your thumb up. Pull your fingers out of the way. That gives your patient some support. I'll let you look at that. And that right there is a lateral view of your thumb. Yes, it makes your arm kind of hurt. You got to be aware of this for your patients. So sometimes I'll even move the board around. That makes it more easy for them, because that That made my arm feel so much better. Rather than having to do this and have to force your patient to do a thing that's uncomfortable, because this flips your elbow out, you can move the image receptor. It's not a problem. You will still produce radiation as long as you still enter the CR into the MCP joint right here, and you include all the way up into the wrist to the trapezium right about here. Okay, I have it marked on my hand. That's where the collimation is. All right, so that is your lateral. Here's your AP. There's your oblique. All right, so that's it for a thumb. Ooh, hand. This one's not as hard. It is quite easy. There's a PA hand. Make sure all the fingers are spread apart. If you have fingers that are, with injury and they're overlapping, obviously, don't go pulling fingers apart because that can just injure your patient more. But you need to make sure that your patient is relaxed and that the entire plane from your forearm to your wrist is in line. And that's what we are talking about when we say the entire plane. This bone here connects to your wrist. Well, I need to see a little bit of my wrist here. So I want this to set down. I want this to line up and be in the same long axis as what I'm doing. All right. So here's a PA hand. This is AP. This is PA, right? This is anterior. This is posterior. So we're going to put our hand down, PA. Dun, dun, dun. Let me scroll. We're going to put it down, PA. Now the central ray is going to enter through the third MCP joint. So this is number 3. This is the metacarpal phalangeal joint. This is the metacarpals in the palm of your hand. And these are the phalanges, right? So this is the metacarpal phalangeal joint. It is the knuckles. When you do a knuckle sandwich, put that straight right there, and we're going to collimate out to include the wrist joint. All right, it doesn't need to go super far on the forearm. It just needs to include the wrist. On all x-rays, we should be including the wrist above and below the area of interest. All right, so we're going to include the wrist, shoot that, and make sure none of the fingertips are cut off in the collimation. Now, a lot of people are like getting really close to the fingertips. I'm like, well, you can just move that thumb over a little here, move that finger over a little here, make your collimation a little bit tighter if you want to do that and not have it all splayed out. Because then when you're opening up the collimation, you're putting more radiation and you want to tighten that beam and put it together. So if they don't have to have all their fingers splayed out for no apparent reason, you can make it like this. Okay, so our next projection for a hand is going to be an oblique, which this one is super easy. And it's best if you have a patient who doesn't quite understand, just show it to them. All you need to do is plop your hand down and then you raise it up just a little bitty bit. That's all you really need, and I will show you that. You see, that's going to be about your oblique. All you have to do is lay it flat and then tilt it up. I'll show you that from that side. So if it makes it easier for your patient, move the IR. Turn it up. And this is going to get your entire hand in an oblique. You can see all the fingers in oblique. Make sure your fingers are apart a little bit because the doctor doesn't want to see, he wants to see all of the bones. Be sure to mark it and be sure to collimate out past the wrist. And you're going to direct the central ray to the third MCP as well. Oh, good. So it's going to be the third MCP. This is where you direct your central ray, include your collimation. Bam, there's your hand. So a lateral of the hand. So several places have different routine projections for a lateral. I'm primarily familiar with what is called a fan lateral, and I'm not entirely sure how they do it here at Miller Memorial, but they may just have a straight lateral. Okay. If you have a straight lateral, you can't really see anything in the bones though. And this is why most radiologists will have a fan lateral be the normal. So this would be a lateral hand, just a karate chop, right? But a fan lateral means an okie dokie sign, all right? And that's pretty much what I tell people is you put your palm, your pinky side, palm down, and then give me an okay sign. That's what I want to see. I get an okay sign, I try and pull the pinky out. This puts all the fingers into a lateral position, including the first and the thumb and all the bones of the hand. All right, you get your lateral set up like that. And your central ray is going to be directed to this joint right here, which is your second metacarpal phalangeal joint. It's going to go right in here. You collimate out, include the wrist. All right. So that is everything, including the fingers, the thumb, and the hand.